Thank you very much. I'm Dr. Sunil Murikar. I'm talking about the Wolfram language. There's no conflict of interest, but I have to tell you that I've done Wolfram language and I help with statistics and research in Wolfram language. The purpose of the study was to study the conventional AI tools in pediatric ophthalmology versus Wolfram language analysis for predicting the outcome in terms of clinical results and the money spent. Globally, we know that roughly around $1,110 per capita is something which amounts to 9.8% is spent on health. In Asia, it's more, and it pushes many people into poverty. 10 million children are affected by rare diseases and with a genetic etiology, and we do not know which case to operate and which case to not operate, where to expect a result. So we use AI. So what is AI for people in a hurry? You take an image, you process the image, put it into computer science, machine learning. The machine tells you deep learning, which tells you a CNN, a neural network, computer vision, and gives you object recognition, and with that you can find out whether that case is going to succeed or not based on what other people in the past have done. So what is known? Genetic testing has been used. So AI can be applied on the phenotype. So you can look at the phenotype, how the person looks, and do the genotype determination without actually doing a genetic testing, and figure out what complications are expected. What is also known is that the TRACK AI project has been used extensively so far. It has also been used in ROP, and Brown et al. Have developed a software. And these are the various papers on ROP, the retinopathy of prematurity. What is also known that it has been used in pediatric cataract to figure out whether the patient is going to have a high IOP or a PCO severe, and also been used in myopia. But what is unknown is whether it actually has an economic impact and a real-world grassroots impact. Audits are missing in literature, sensitivity, specificity in other eye disorders other than what I have said, and newer languages like Wolfram and its economic impact is unknown. Wolfram is a further refinement made to improve prediction of success and guide treatment. You use the human neuronal network, and between Watson, IBM Watson, the AI, normal AI, and the Wolfram, there are more computational algorithms, and real-time data can be input. And you get an extended report as well as a definite answer, not just ranked answer probabilities. The cloud, like you use a Python, the Wolfram cloud is much more extensive and better. And so the methods we used as study design was real world data. So real world data is very much missing. So we did a clinical audit and economic audit comparison and sensitivity specificity testing. The inclusion criteria was all pediatric cases in the last 1 year. So 1,923 new pediatric cases were analyzed qualitatively using 2 different AI methods. And we compared this with audits over the last 10 years. So we had our own data, conventional data to compare with in previous years. And we had done audits of audits. We use the same standard method as used by Shiraroko. So consenting blood collection, you look at the clinical data, then you look at the research data in terms of genomics and go back to the clinical data and find out whether that correlates with a phenotype. The same electronic data capture and electronic health record, and then you put it into the database. And on the basis of the database, you find out associated diseases, also look at variant analysis and look at this workflow and come back to feeding this. So that's the advantage with Wolfram, you can feed the data back into the system. So the phenotype analysis and the genotype analysis were done. We phenotype participants using automated and manual process drawing from the EHR and used available AI datasets for rare diseases to predict the genotype from the phenotype, and compare that with real genotype data. So these are the available AI and machine learning data sets in literature. So you can pick up from any of them. We in fact did most of them and incorporated many of them. And cases were selected on the basis of classic algorithm and then analyzed for success to test the algorithm. So cases were compared which were done in spite of the algorithm saying that it is going to fail, and with those who refuse surgery when the algorithm suggests a success, and 2x2 table. We used a model to do the hybrid decision tree analysis. These are the support systems which are available, decision support system. We found out that genetic conditions are very easy to identify. Ancestry and consanguinity is a very important factor. So there are some of these results. The hereditary blepharophimosis, you don't know whether it is type 1 or type 2 or OHDO blepharophimosis, whether to do chromosome analysis can be done. But Wolfram image analysis detects at 98% and 93% specificity with years, microcephaly and all physical features. The algorithm in its conventional form had a sensitivity of 83% and specificity of 89. In Wolfram form, it increased to 87 and 94. Combined, overall, it had an accuracy of 96%. The overall cost per patient on an average reduced by 15%. And when Wolfram was used, it was much more. Comparing Wolfram to conventional in the artificial intelligence, you can see down below in red is our study. All the others had 89, 93 and all. We had 98 and 95% with high IOP predictions and severe PCO predictions based on the configuration of the lens. Both screening models under societal and health system gained a total of 16.11 QALYs. The telemedicine model had significant lower cost. Under this model, the total savings per person was 79,243 per person, and 43 for the societal and health systems. Some of these cases, cryptophthalmus, these are the results. So would you offer FREM2 gene is something that you would like to find out, but would you offer in particular cases? You look at the phenotype, put it into the system, and it'll tell you, no, you don't do that in the right side, you do it in the left side. Corneal dermoids, if you see a PITX2 gene mutation with a ring-like dermoid, you know that this PITX will be associated with a pituitary abnormality. Clefting syndromes, these are situations where you would not do a surgery in this particular patient, whereas other cases you would see that this is a clefting syndrome with a cleft lacrimal sac, cleft canaliculi, and nose and lip and palate. But the surgery was success because we got to know about that, and also in the sibling. The associations are with these conditions, EEC syndromes, clefting, R298Q can have a right ventricular cardiomyopathy. So you have to be careful. You would like to treat the patient, but you don't want to kill the patient. Hereditary dacryocystitis is something that we used. Osteoporphyrosis, LMD, and clawfoot, thyroid, squint, complicated squints, and comparison, this was better. NIRD, it was better. Prader-Willi, optic nerve, neurofibromas, and syndromic ptosis. Sedation and anesthesia were considerations, and we discussed that only 5% had treatment so far. We now got treatment in 23%. Application, it gives you cost-benefit analysis, and conclusions, it is superior to conventional AI. Thank you.
Yeah, Dr. Morekar, actually your topic was a bit difficult, Greek and Latin to us to understand.
So I'm sorry, I can explain it in a couple of words in case you ask me something.
Yes,
because I've been working on it.
So would you tell how it is beneficial?
So the major advantage is that when I started off with genetic testing and precision medicine 10 years back, I had to send patients for a genetic analysis, genome analysis, which used to cost 60,000. They used to give us one disease. So for Prader-Willi or something, they'll give us 60,000 for one disease. Today it is available for 9,000 for 12 diseases. But still 9,000 to send a patient to a genetic analysis to figure out what are the various conditions in him. Versus that, if I am able to take a picture, so you take a picture of my face, and looking at my face, look at my nose, look at my ears, looking at how my ears look, you can put it into a database, which is an available database internationally for rare diseases. So these databases tell you that this is the phenotype, which is something that looks like an RHD3 or a PITX. So this patient will have a pituitary. So I will not spend money on MRI and all. In all patients, I will do it for this particular patient in which I expect the pituitary to be there. I will not operate on a patient where I know that there is a sedation risk and the patient will die. So what we calculated is that per patient, what would we have spent in terms of getting the patient admitted and then redoing the surgery, So there was this aniridia patient in which we redid the surgery 3 times, and then this patient has an anterior segment fibrosis syndrome. All we needed to know that there was a WAG gene positive. She looked obese, everything was fine. So now I know that this patient should not have been touched, it will get an anterior segment fibrosis syndrome. Another patient which we have done where we know that it is not a WAG positive, so we know that this is the patient in which you should do it. So which patient should we do, which patient we should not do? Cataract, which patient will get a very high IOP, which patient will get a PCO, severe PCO in spite of what we do. So should I do a primary PCC? So all of this is something that this thing tells us. We've saved roughly around 1 crore rupees in 1 year in one center.
I think genotype and phenotype don't always match, and I think
they don't always match.
Experience, I think that is more important, and each patient is different.
Excellent, excellent. See, because all of
have
you
a very uniform approach
so
to everyone.
your experience plus his experience plus experience all combined together, you submit to AI, and AI has the experience of 2,000 doctors. So that AI now tells us, okay, your 200 cases, his 200 cases, and then gives us.
It can help, you're right, but I think ultimately it depends upon your experience and your expertise in operating these patients. So it can help. That's as adjunct. I think it is
tried that.
a good
So
idea.
I compared this with my experience. I'm operating for 25 years.
Yeah.
Each time I say कि ये तो fail होने वाला है, AI says कि pass होने वाला है, माने success होने वाला है. I am proved wrong. The AI is proved right. Some people I have said don't do it, मत करो, ये सब fail हो जाएगा. Somebody else does it and it becomes better. Here I say this is going to work. 25 years I'm working with this thing. So I tried to convince even the ICO with. I'm a member of the health committee there. Yeah. So I tried convincing people that you put AI and you will realize that once you start using AI, our experience, 80% it is better, but
Yes, it can help. I agree with you.
96%.
But I think basic thing is that how much we understand ourselves and experience and our expertise in operating these
In
cases.
case we employ a computer analyst, so most of my work is done by the computer analyst. He
Yeah.
says, "Sir, machine बोल रहे मत करो."
Yeah.
बोले मेरा experience बोलता है करो.
And
It
rare
fits.
diseases have lot of phenotypic variability. That's another
Absolutely,
problem. And
absolutely.
genotypes also can
Dr.
be
Mai?
quite variable at